Healthcare Inequities from a practitioners, therapists, doctors perspective. This very important issue, and we can't solve all the problems tonight. There's no way, it's too big, but I tried to go over basically the problems, solutions, what we're doing in our individual practices and lives to move the needle forward, and also tips and advice we can give to people to navigate despite this issue, healthcare systems well despite this issue. So that's what we're going to talk about tonight. So I'm not going to keep gabbing. I'm going to allow these people to do a little bit of intro of themselves. Let's keep it short, but who you are, where you're from, and what your focus is in your practice would be great. Thank you, ladies. Alexia, you can go first.
Hi, everyone. My name is Dr. Alexia Gaffney. I'm a triple board certified infectious disease subspecialist. I am also a mom, a wellness coach, a stage 3 breast cancer survivor thriver. I have a PALB2 genetic mutation. Out of that experience, I've become a breast cancer advocate and a health advocate for underserved and underrepresented minority populations, specifically women. And I'm happy to share my personal experience, my physician or clinician experience, and some of the things that I've observed and I think can help in this conversation tonight.
Thank you. All right, Dr. Elise.
Hi there, my name is Dr. Lise K. Cantu. I am a physical therapist here in Fort Worth, Texas. I'm a certified lymphedema therapist, and I'm just kind of in general obsessed with helping people live better after a cancer diagnosis. So I also have a private practice here in Fort Worth where I treat exclusively patients after they've been diagnosed with cancer and patients who are experiencing lymphedema.
Sophia.
Hi, everyone. I'm Sophia White, and I'm in Canada. So I reside in a very small town, southwestern Ontario on Lake Erie. And I have a very different kind of path that I took. So I am a lymphedema therapist, but I'm also a wound therapist. And I'm currently in school to do my Master's of Human Science. And I have the entire country. So I work in a position where I am a consultant for lymphatic malfunctions. So I see any type of lymphedema, whether it's primary or secondary, and most of the time it's quite complex. So very different, and I cover all the different provinces and see all the different funding models.
Thank you. And I'll just say a bit about me. As you know, my name is Bisa Dobson. I'm one half of the team here at Conversationally. I'm a lymphedema therapist in practice in downtown Toronto. And mostly my practice, I see lots of cancer patients, primarily breast cancer, but lots of gynae and head and neck as well. And I'm just really passionate about helping people move towards a new normal and feel really empowered so they could actually thrive with their lymphedema instead of cowering in the corner, not being afraid to live after diagnosis of lymphedema. I think that's really important because people can live really well. So I try and teach people that they can. All right, so let's get into it. So to start, to make sure we're all on the same page and clear about what we're talking about, I want to read some definitions that are on the Canadian government's website about health inequity and health equity. So I'll start with inequity. So health inequity refers to health inequalities that are unfair or unjust and modifiable. For example, Canadians who live in remote or northern regions do not have the same access to nutritious foods, such as fruits and vegetables, as other Canadians. So, health equity is the absence of unfair systems and policies that cause health inequalities. Health equity seeks to reduce inequalities and to increase access to opportunities and conditions conducive to health for all. So, based on that, here's a question. Based on the definitions provided, can you share your thoughts or perhaps a story from your practice or maybe even your personal life that demonstrates how health inequities have impacted the populations you serve or yourself? And I'll start with Sophia.
So I see this quite often because I do cover all of the country here in Canada. We have some very northern populations, and it impacts them severely. So we do see that the lymphedema population does suffer from severe lymphedema, and there is definitely wound formations that are that do come from that as well. A lot of these individuals do not have access to lymphedema therapists. And most of the time in those provinces, they don't actually have a funding model to provide for the garments that they require to provide the maintenance. So it's a huge impact here in Canada. And a lot of the times it's the northern provinces that we see, but we can see it across the board in all of the provinces themselves.
All right, Elise?
Yeah, so one of the things that actually came out within the last few weeks here in Fort Worth, Texas, is the significant disparities between life expectancy within my county. So in Tarrant County, this is where Fort Worth is based, there is a tremendous range of wealth and also not wealth just within one county. And it was so interesting. There's about a 12-year difference in life expectancy just in this county, depending on your zip code. And I think that unfortunately is such a very visual representation of just how much it really affects a person's ability to live and thrive. And this is considering both cancer, but also lymphedema. And, despite being in a fairly established metropolitan area, we do have some great resources, but unfortunately, lymphedema is one of those we do not. We have a 3-month plus wait list for a lot of our patients to receive lymphedema therapy, and that is not a PT only issue. That is unfortunately across the board. And again, I think there's just been, unfortunately, a lot of recent literature that is just highlighting how significant the health inequities are in my region. It's wild.
All right, Dr. Gaffney.
Yeah. So where I see health inequity all the time as both a breast cancer patient and survivor, as well as a clinician, is like young Black women, right? I'm sit on panels all the time talking about health disparities, where do they come from? And I will have my colleagues, fellow physicians say, well, I treat my patients just like I would treat my mother. Well, if your mother's a middle-aged white woman, and we're talking about 35-year-old Black women who are at risk for breast cancer, giving them the same care as your middle-aged white mother is completely inequitable. You're comparing apples to oranges, right? If there's a population who is more likely to get diagnosed with a more aggressive stage of the disease much later, it's more likely to kill her. And she's more likely to have prolonged comorbidities as a result of the diagnosis and the treatment. It does not make sense at all that you treat her the same way you would treat your middle-aged white mother, right? That means that you're treating someone who's at extremely high risk for the disease-associated morbidity and mortality. You're treating them the same way as someone who has a completely different relative risk and a completely different outcome. And people do not understand the definition of inequity or equitable healthcare. And so they can't show up any better because they don't really know how to define the problem. And our healthcare systems are failing us. When we have these conversations, everybody, enters the chat with, well, we have these problems because of poor insurance and the poor health literacy and all of these different things. But at the end of the day, like if our patients are showing up at the office, it is up to us to determine how to best care for the patient sitting before us. And until we take those blinders away from our providers, who 95% of them do not look like the population they're serving, or don't look like the high-risk populations they're serving. Let me correct that. Then we will never get ahead of this problem. We have to stop blaming the patients for some issues that are purely just bad and inequitable care.
Thank you guys so much. That's really rich commentary. What I will add to that, I think you touched on so much, is as a Canadian, we have free healthcare for the most part. Insurance isn't the issue, number one. And number two, as a general thing, a theme my friends and I in healthcare talk about is the fact that our patients who are differently abled, elderly, queer, different religion, don't speak English well, of color, and female, rich or poor, are the ones who come in and tell us these harrowing stories about practitioners of all levels not paying attention. And that just breaks my heart that at a time when you're vulnerable, you're fighting to get heard, So it's something I think about a lot.
It's really problematic.
Yes, it totally is. All right. So moving on to the idea of barriers, I want to talk about tech in healthcare because that's a big one. So we have patient portals, health history forms that are online, appointment reminders come via your email, everything's going digital, your receipts for things, everything. So This, of course, makes it really convenient for people who have access to smartphones and computers and Wi-Fi, but for people who do not, they're getting locked out of the game and don't have equal access. So this is just one example of a social determinant that is impacting healthcare. What do you find are the most common barriers that the patients you interact with are facing when accessing healthcare? And I'll start with Dr. Elise.
Ooh. I mean, how much time do we have, y'all? Like, I think, again, specific to my area of practice and my geographic area, one of the biggest barriers I think that we as a local community have is we do not have the infrastructure to really support the patients who are diagnosed with cancer, and especially patients who are diagnosed with lymphedema, beyond the very acute cancer treatment. Like, let's say my patient is diagnosed with early stage breast cancer and undergoes treatment and then develops impairments as a result of that. We do not have the system set up to support her as she continues into this long-term survivorship phase, right? So she's done with treatment. She's not seeing maybe her oncology team as often because she doesn't need to. And so these patients are falling through the cracks. And so what I'm seeing a lot of times is because we don't have this safety net to catch patients before they get into, I've had this problem for many years now. It is now a chronic issue that I'm dealing with, exacerbated side effects and whatnot. That's when I'm seeing a lot of my patients. Many years after their diagnosis, their impairments, like I said, maybe that's lymphedema, maybe it's something else, are to the point that I may not be able to reverse it. Like, we may be kind of adapting to a new baseline because we cannot get back to where we were. So I think barriers wise, like, again, the big one, I don't think we have the system set up to support the patients that we have, unfortunately. And then even if we, even with the systems we do have, the actual access to the care, I mean, it just adds on a whole other layer to it, unfortunately. There are multiple oncology clinics and facilities in my area, but that doesn't necessarily mean that patients can access even the ability to get diagnosed with cancer, let alone get referred to an oncology clinic to where they can get the treatment. So, like I said, y'all, I don't know how much time we have because we could go through a list, but I think those are probably the biggest two. If I had to narrow it down, like, those are probably the biggest two that we're facing right now in our community.
Thank you so much. Sophia?
Yeah, so here in Canada, we have a few big barriers. One of the largest barriers would be the financial barrier, because we don't have a system that pays for, some of the provinces don't even pay for the garments. We don't have payment for treatment. That is a huge barrier for these patients. I see a lot of patients who don't have the financial means, that their lymphedema just gets exacerbated and they end up in hospital for whether that's cellulitis or some sort of chronic wounds. They end up in hospital. So we're just increasing that rate of hospitalization. And then the garments as well. So, here in Ontario, we have a 75% funding model, but other provinces have nothing. And some of those garments range up to $500 to $1,000. And then, patients are getting those every 6 months. So it's quite costly. And that's the first thing that that's one of the first barriers. And if they are on a government social assistance program, that doesn't pay for the treatment either. So unfortunately, that's always a huge barrier. Another barrier here in Ontario would be, in order to get that initial funding for those garments, patients do have to see a specialist. And if they've never had the encounter with someone like an oncologist or a vascular surgeon, they're now waiting for, upwards to a year to have that signature. It's not X, Y, and Z, so it must be lymphedema.
Wow. All right, Dr. Gaffney.
Whew. So many issues. It's like, which one to pick? I have a practice that's very split. I inherited a 40-year-old practice. So I have all of these folks in their 70s, 80s, 90s. And with the pandemic and everybody being forced to stay home, technology has been an issue for them. I have patients who still have flip phones. And so just accessing the office for a telehealth visit is impossible. Not being able to access their medical records. This is not a generation who even grew up with a desktop computer, much less a laptop, and certainly not an iPad or a smartphone. So those who aren't just very tech savvy, who aren't connected to grandchildren who can come over, or children who can come over and hook these things up or sit with them through a visit, they face issues with access because of inability to utilize the technology. Some of them are too old to drive or unable to drive as a result of their health condition. So getting to the office is problematic. And then we have county services like SCAT buses or medical transportation, but you can't just call up and say, hi, I need this transportation to my doctor's office. You have to go pick up a form from the transportation department. Then you have to have an in-office visit with your provider to fill out the form. The form cannot be faxed. It cannot be a photocopy. It has to be an original. Everything has to be signed, stamped in the office, and then the patient has to get it back to where it needs to go. So the difficulty in even accessing the available services, if they are even knowledgeable that they're available, is problematic. Transportation is one that I'll stay on that continues to be an issue, even for my younger patients who may be differently abled and unable to travel on their own. Some of their insurance providers will force them to see a provider within an 8-mile radius of their home. And if the provider in the 8-mile radius of your home is not someone who's going to give you equitable care, is someone who spends 4 to 8 minutes on average with a patient, and they want to travel 20, 30, or 40 miles to see someone like myself or to go to the university medical center, their insurance may not cover that distance. And so, we have so many barriers that is just one of many common problems we see in the United States and within New York City and state. We have so many different types of insurance payers, and which one works with your provider, which one works with your provider and the institution they work within. Are you primary? Are you a subspecialist? What's the co-payment? Are you going to get balance billing? Like so many other insurance barriers, financial barriers. And then we can't even scratch the surface without talking about healthcare literacy, which many people do not have. And as a healthcare provider, I always wonder what happens to these individuals who just don't have good healthcare literacy, just do not have the wherewithal to comprehend some of the things that they're facing, and they don't have a family member who's available to come 9 to 5 during business hours to sit with them in the office, or they don't have a healthcare professional in their family to call up the doctor later on in the day and sort it out for them and define the information or explain it again to them. Like there's so many layers, and the time constraints that we're forced into just continues to consistently drive an already big problem. It just makes it catastrophic at the end of the day.
Mm-hmm. Mm-hmm.
Okay, I love all your answers. I was like, what do I add? But what I will say for me, I'm keenly aware of now as a therapist working in Toronto, where we do have free healthcare for lots of things, not for the services I provide for lymphedema patients. I'm very aware of how socioeconomics can totally change the trajectory of your health. So I have a patient now who, has a lot of money to be able to do all the things for she's in breast cancer treatment, active cancer. So seeing a naturopath for hyperbaric treatment, seeing the laser for lymphedema, going to the hospital, of course, and just on and on and on. And she's doing so well, and the fact that she's even alive might be due to the fact that she has more money than the average cancer patient versus my other patients who maybe not in as dire straits as her as far as the initial stages of her condition, but like way behind as far as the care of the lymphedema, just because they can't come to often. And sure, I teach them what to do at home and how to take care of themselves, and we do all the things we can to make it as economical as possible. But the bottom line is if you don't have enough money to take care of yourself the way you need to, your health is just not as good. And that's something just really keenly aware of over the past year for sure.
Yep.
Yeah. So many things in that vein as far as barriers. So now I want to talk about equity in healthcare regarding gender inequality because we all can relate to that. So in doing research for this discussion, talking about gender equity from a practitioner perspective and also patients. So practitioners, doctors are 50% or more of most med schools. Internationally, females are 70 to 80% of the healthcare workforce, but women represent less than 3% of the people in the C-suite level of healthcare settings. So really abysmal stats there. It seems like in healthcare, like in many industries, women are stuck between the glass ceiling and the sticky floor below in low paying, low mobility roles. So they can't move up very fast and definitely don't move as fast as their male peers. And then from a patient perspective, research for diseases that affect women generally are underfunded, particularly reproductive health. And this stat blew me away, like blown away. So it wasn't until 1993, and I imagine it was the same in Canada, but the NIH in the UK, FDA in the States, that was the year they made it mandatory for women to be included in all pharmaceutical trials. And because that wasn't mandated till then, between 1997 and 2000, 8 out of 10 of the drugs released to the market in that period had more serious side effects for women than for men, which is crazy to think about. So clearly there are giant gaps that need to be addressed to make our healthcare system more equitable for everyone, and particularly around gender, based on those stats. So what are signs that you are seeing where you live and in your work that these realities may be shifting, especially now that COVID has resulted in even more of a focus on the social determinants of health and health inequities? Whoever wants to go first. You have to volunteer. Thinking, you're thinking.
Listen, I don't know that universally they're shifting. What I will say is, and what I've observed and experienced as both a clinician and as a breast cancer survivor and advocate, is I feel like it's the patients and the patient advocates that are making all of the noise to say, hey, like, here's a problem and we need to fix it. And then the pharmaceutical companies, the healthcare companies, the big medical centers then jumping on board and saying, oh, yeah, we need to partner with you all on that. We need to talk about this. We need to do this. But I don't think that these issues are being taken up by the big healthcare systems. I think they're being taken up by the advocates, the patients, the people making noise in the spaces, and then everybody else is coming on board. You know, it took for people to start calling systems out and really just outing all the major players involved and saying, like, this is problematic, this is what's wrong. You know, if you talk about COVID, right, in like Long Island, where I live and work, which is a suburb of New York City, our COVID death rates for intubated patients was like only 15 to 20%. In New York City, it was like upwards of 80, 88%, right? And so it wasn't until people started calling that out, saying, you know, these hospitals are underfunded. They don't have enough resources. There's no clinical trials going on here. It wasn't until all of that started being uncovered that it then became, oh yes, we need to work on our diversity, equity, and inclusion. It took so many pivotal moments here in the United States to kind of blow the lid off of so many things and to show how everything is interconnected, right? Our environments and our health, our ability to work and make a living wage or to get commercial insurance, and our health, what health systems we have access to and what our outcomes are. So it took for that to happen, for people to really start to get on board and say, oh, okay, how can we help? How can we change? And needing the patients and the advocates and the folks who probably in the background have been screaming all along, but aren't in the C-suites, those folks making noise to come together and try to make some changes happen. But sadly, I can't honestly say that it was the major players that caused this shift. They just were like, oh, y'all are making noise and we better get on board. It's the right thing to do. I got to check my DEI box.
Mm-hmm. If I can piggyback off of what Dr. Gaffney has been saying, I think, and again, whether this was like divine timing with COVID or it just kind of happened this way, but we are in an incredible age for the access to information that is available on the internet and on social media. And I think because of this, and again, going back to a point that was made earlier, is not everybody has access to this, right? We know that not everybody has the access, the resource, the know how to use these different platforms, but there is an increasing population that is getting now to adulthood and into like young and middle and even like older adulthood who are active in communicating this information, which I think is really helping. It is not fixing things. So I'm in total agreement with Dr. Gaffney, like we got a long way to go. But I think the advent of this available information and online community that is being built, unfortunately, through these really tragic and catastrophic circumstances that we're all talking about here, like social media is huge for this. And I think this is helping to put pressure on those decision makers who can make the environment and the healthcare systems, at least here in the United States, more accessible to other individuals.
And I'm going to echo the same. I've seen some great things coming out of social media from the youth groups. The awareness, the different pathways that they're kind of pointing each other in. So I'm starting to see a lot more individuals that have the options before things get, their lymphedema starts to progress. So I'm starting to finally see those patients in those early stages that they're actually aware of funding models, they're aware of all the therapies that are available, they're aware of self-bandaging and things like that. So once again, that social media is huge. And I think with COVID, a lot of us went to social media and we were able to provide that education and awareness. And that just spoke volumes, literally. So we're now seeing all of those new patients. And the other thing that I'm seeing a lot too is that here in Ontario, because we have that funding model, we've had it for, I think it's like 16 years or something along those lines. But some of the times it was very hush-hush. A lot of the times, you would talk to patients and they wouldn't know about the funding model. Now with COVID, more patients are aware of funding models. They have more access to that. So whether, because of COVID and a lot of individuals lost their positions and now they're seeking more to see if there is grants or funding models, there's more awareness, and it's a government program for these patients. So it's great to see that finally more individuals are using this program.
Awesome. Okay, so based on what all you said, there's a common thread here, the idea that the changes are coming from the bottom up. What do you think it would take to ever have it be reversed? Is there anything that would shift that balance?
So it's really interesting you say that, because in Saskatchewan, they do have a really great funding model. Once you've had a cancer diagnosis and you've had surgery, you have 100% coverage and for the rest of your life. That occurred because one of their individuals in Parliament had lymphedema. So that came from the bottom, or sorry, from the top down. So, I mean, that's a great example. Healthcare is very different in that province, and individuals have access to treatment. They have access to lymphedema clinics. So, I mean, that would be great if we could transfer that across. I think it takes someone to live that journey, to feel the way those patients feel, in order to push those feelings and to make movement from the top down.
Yeah, I was going to say the same thing, that it's going to take for someone to have that lived experience to get it. And the other thing it's going to take is money. It's going to have to cost money. It's going to have to be a financial hit for having disparate outcomes for different groups, for it to come from the top. Everything is about the bottom line. Everything is about the almighty dollar. And so until organizations, hospital systems, whoever, insurers get financially penalized for acting in a way that results in consistent disparate outcomes until there's a financial hit. I don't believe that it's going to change from the top down.
Mm-hmm. I think it's going to take a tremendous amount of continued pressure before we really start to see that like trickle down effect. I think, again, I'm in agreement with Dr. Gaffney. I think it's going to be more of a bottom up until that both like societal pressure, but also like the financial incentive is great enough to tip it to where administrations, of hospital systems, of insurers, etc., are finally like, okay, they're like, it's almost like, and this is very negative, I feel like their hand needs to be forced in that way to really make it change and make it lasting change.
Yeah. And it'll take a really long time for it to be a societal pressure. Here in the US, there won't be that societal pressure for a very long time because people feel like if this group is getting it, then I'm somehow losing. And so I can't go fight for everybody to have the same outcomes because that means somebody is taking away something from me. And it absolutely doesn't mean that. But the powers that be have folks pitted against one another. And they really strongly and firmly believe that. And these are the kinds of things that I hear every single day in my office. I mean, sometimes I'm like looking like you do see who you're talking to, right? I'm like, know your audience, but okay, you want to bring it up. Let's have a conversation and let's talk about it. But I think here that societal pressure is going to take a long time. Like our young people are a stance for everybody having everything. And I love it. I'm here for it. I'm right with them. We have enough of everything for everyone to have. But we do have some older generations and some folks who just choose to continue to be willfully misinformed, who push back and feel like if they have what I have, then that somehow means that I'm losing and won't stand for it.
Amen. What else can I say? So well said. All right. Okay. Thank you guys so much for that. So, question 4, tying back to people who are marginalized and who are othered by the healthcare system. It's not lost on me that those are the people who also report having to gear up and brace themselves to enter the system and know they're going to have a fight in their hands to get the care they need if they get it at all. They have to advocate aggressively to do so. So, it's definitely obvious that all of us as healthcare practitioners have our own biases. And that impacts how we show up as practitioners and how we serve the populations we interact with. So my question is, what are some ways the spaces you work in, so the healthcare systems or your practice, and you work in, and my question is messy. What are some of the ways the spaces you work in and you yourself as a practitioner personally encourage all staff, including yourself, to examine and/or have open conversations about the idea of bias and how it can impact your work?
I mean, we have to do diversity training, and we have to do it annually. It kind of feels like, didn't we just do this? But it does get the conversation going when we're all sitting and going through these modules and considering the different scenarios that are presented and what bias might look like. And my staff just happens to be all women. And just women of different races and cultural backgrounds. And so sometimes the things that we experience in the office, have us have these conversations when the coast is clear, like, do you think that person would have spoken to us if we were men? Do you think that they would have treated us this way if, a number of things, people have said to me, like, do you think this person treated you this way because you're a Black woman? And so the conversation is ongoing because it's impossible not to have it just based on our experiences. But, the thing that I encourage my staff is to just always not to take things personal, to try to be open-minded, to check our own biases, and even just to discuss like culturally how we might view the same scenario differently. Just because we all come with our own biases and our own cultural norms, our own preconceived notions. And so, sometimes we want to believe that because we're a diverse group of women, we're somehow free from bias. But we have, I make sure to remind them that we're not free from it. We sometimes joke about it, but we know for sure that we aren't. And I feel like it's a consistent conversation that that we have. And I think that's a good thing. We all bring something to the table, and that's something to talk about as well. Like, that conversation isn't all negative or disciplinary or things like that. Like, there's some good that comes out of talking about these issues as well.
Mm-hmm. Mm-hmm.
We're the same way. We're a team of females, different ages, different backgrounds. And one of the main things that we always talk about is the psychological aspect, so the mental health aspect. So it not being biased towards that, it's really important when we're dealing with complex patients to completely take that bias out and look at it completely different without any of, I don't want to say the judgmental eyes, but thinking of, why this is occurring to this patient and why this patient is feeling this way, because lymphedema and the treatment, and, this could even be a reminder of even a motor vehicle accident or cancer or something like that. It could be a traumatic experience for them. And there is that mental health aspect that is potentially causing barriers for them. So we talk about that mental health factor all the time, and just making sure that we also look at that as a factor.
Mm-hmm. For me, because I'm a private practice owner and I am the employee of my private practice, like there's nobody else right now. But I do have a platform where I'm teaching other physical therapists how to treat patients with cancer. And I think it really has to start with me. I need to be continually examining how I'm approaching patients, how I'm approaching situations, and the information that I am putting into my brain about my patients and their lived experience. Like I don't think there's a finish line. This is always going to be a work in progress that I need to be doing with myself first, with my, more external like circle of influence, but then also my community. And so I think, again, constantly reassessing where are we at right now, really taking almost like getting outside of myself, like Sophia was saying, to really look at the patient and their individual set of circumstances. This is something that Dr. Gaffney spoke on, I think, in the very first question, but I cannot treat my patients all the same. And as a really young clinician, that was like, of course I'm going to treat all my patients the same. Like, I'm going to give them all the love and compassion. But in doing so, in creating a very uniform approach to my patients, I am neglecting certain factors and lived experiences, and frankly, barriers that they individually have, that if I take a blanket approach, I am ignoring altogether. And so I think challenging myself that every patient is different, and I have to approach it that way and really dive into what is at play here, not just the surface level of my patients coming in and they have pain after a mastectomy. It's like, no, there are many, many other things. And so for me, it's a continual journey of discovery, of education, and then trying to share that with my audience and with my eventual employee someday that I'm going to have, if I'm really going to make a difference big picture wise.
We always say too, it's like peeling that onion. So it's the onion factor, right? We're always taking off those layers slowly, trying to figure out exactly what you said, Elisa, determining how we're looking at that patient and the experiences they had and the life they lived, because like you just mentioned, that's going to affect how their treatment is and how we all communicate to each other.
Oh, so beautifully said. So
Yeah,
everything everybody said. What I will add to that myself is that, like Dr. Gaffney, woman of color, definitely moments when I am a person who would be marginalized in the space if that was going to happen to me, but also very, very aware that I need to look at the areas where I'm falling down the job and things I need to work through. And be very honest about this, though I have no bias against anybody's LGBT, they, them, I can say it, but I mess it up all the time. And one of my clients said to me one day, I love that you're trying, but this is like knowing my name. And just a look on her face, I'm like, okay, like fix it, you know? So like knowing that if I'm going to ask people to respect me as a woman and as a person of color, I need to be, as much as it's hard and uncomfortable and difficult, I need to be pushing myself to learn and grow through the discomfort so I can show up for my patients the way I want somebody to show up for me when I enter an office for care. So just putting that out there as well, right? And often I have a lot of discussions with race with people who are not racialized, and they're like, oh, well, you obviously know everything. I'm like, no, there's stuff that I need to work on too, and I think it's sometimes hard to hear from me, but yeah, I have stuff I have to work on too. So
we all do.
Thank you. Beautiful commentary. All right. So moving on to another aspect of bias, I want to talk about affinity bias and a bit about psychological safety of patients. So, like I said, when you're ill, you're in a vulnerable position and it's easy to feel scared and unsafe. And you have to enter a healthcare setting anyway with all that anxiety. So some examples I heard of when this would come up, the psychological safety piece, where, like, for example, if somebody's having a diaper change but they can't speak the language of the person taking care of them, that must be really vulnerable. Or if you are a person of color going to space where nobody looks like you, especially since the research shows that patients thrive when they're in the healthcare space that mirrors their community. And also, if you have a condition that is stigmatized, I don't know how many of my friends who are quote unquote fat talk about, doctor, I got stabbed today. Oh my goodness, I'm bleeding. Oh, well, you need diet and exercise. Like, just there's no listening. It's just stigmatized and brushed off. So I think people who are heavy set get that. Addictions and mental health. Some solutions to this, bridging the gap, of course, to show up compassionately and kindly as practitioners. And I heard in one podcast, they were asking some beautiful questions, which I'll share here. So questions they ask patients to make them feel more included and cared for in the space were like, what is most important to you regarding your care? What is the most important thing you want me to know about you? And what is one thing that I could do to make the experience of you being in the space more comfortable for you? Which I think are beautiful questions. So I want to ask you all, what are actions that you're taking to make sure your patients who are different from you, particularly those who are members of vulnerable, stigmatized, or marginalized communities, feel comfortable or safe as possible when you're working with them?
I think just trying to create an office environment that shows that we are here for everybody and everything. My practice is very mixed because it's mostly infectious disease, but it's also some primary care, and I have some very older geriatric patients and some very young patients. I do take care of an LGBTQIA population of patients and have been identified as a provider that is LGBTQ friendly across our health system. And so I am someone who is a stand for all of my patients as much as I can be a stand for them. So, I had a person who was not my office staff member, but covering my front desk who repeatedly misgendered one of my regular patients. And so, in front of the patient, I corrected them. And when they said, well, this is what the license says and that, it's whatever, I made them understand, no, it is not whatever. And it's not appropriate to misgender a patient. It's even worse to repeatedly and intentionally do it. Some people in the community consider it an act of violence. And so this is a medical space. This is a safe space. And this is not how we behave here. So I need you to refer to my patient as they choose to be referred. The same way I want to be called Dr. Gaffney, and the same way you want to be identified as a woman. Like, it's just simple as that. There is healthcare literature that speaks to all of the different types of patients that I take care of. There's not one specific room. So in any of my exam rooms, you're going to see information that covers everything from high blood pressure and diabetes and weight management and HIV treatment and HIV prevention and gender affirming care and mental health conditions. Everything is everywhere because we are here to serve everybody in the way that they need to be served. And I try to do like some of those examples. Like, I just want to be clear, like, today you're hoping to gain what from the visit? Or asking, well, okay, you saw these other providers, what worked, what didn't work, what did you take away from that? How can I show up different? And just saying to people, like, I hear you, I don't know what's wrong, but I believe you. I believe that you're in pain. I believe that you're exhausted. Tell me in which ways your fatigue is negatively impacting your life, so I can get an understanding of how big of an issue this is. Because I feel like so many patients just aren't believed. They're just dismissed as anxious. People don't want to be bothered. That's not what I do. Why do you need that thing? And so patients are being dismissed repeatedly. And I feel it's so important to create a space that lets them know that they're safe here, that I'm listening, that I'm hearing them, and that I want to be part of their solution and not be another person who wasted 4 hours of their life and charge them money for it.
I think that the first thing I say to the patients when I go in and visit and meet them is, what do you want from this session? What are your goals? What does your journey with me look like? Because I could tell them what my textbooks taught me. I could tell them what, the universal treatment is, but that might not work for their lifestyle. So the biggest thing is that I want to make sure that I align with them, with their goals, with their lifestyle. I deal a lot with pediatrics, and they're one of our most vulnerable. So I go in there and I want to make sure that they're comfortable, that the parents trust me, that we have something that's going to work for the entire family. I want to make sure that everybody knows what we're doing. We're working with garments, what these garments are going to do. We're not just going to throw something at you and say, I hope it works, and then I'm going to leave. I want to make sure that you're successful. So I'm going to set you up for success. And that might mean that we're taking different approaches than what your neighbor or someone else that you saw. But I want to make sure that those patients are comfortable with me.
I think for a lot of us in healthcare, we are, maybe not we intrinsically, but we as a system are incentivized to fit in as many patients as possible to make as much money as possible, whether that's us ourselves, our institution, etc. I think the act of slowing down and intentionally showing up to be present fully with your patient is a real act of rebellion in this healthcare system that we are living in today. And so by establishing that you are fully present with your patient in this time, and just so asking the questions, but really listening to what they're saying, and not even just the words that are coming out of their mouth, but maybe also what is left unsaid, is perhaps one of the best ways that I can pick up on some of the things of, they may be testing the environment with me to see is this a person who I can trust with this information? And hopefully they can, right? And so by really being intentional and paying attention to that information, and like I said, I feel like sometimes patients are testing the waters to see, is this a safe place for me? And really picking up on those clues to then say, this is a safe place for you. I'm going to listen to you. I really try to dig deep into, what are my patients' goals? Because as a physical therapist, we write goals for our patients, but not just like patient will walk 150 feet independently. Like, no, what would that enable them to do in their life that is so important to them, right? What is so important to them? How can I then say, you know what? If it's important to you, it's important to me. Let's make a plan to work together to accomplish that. I think that's something that I, as a physical therapist, can really work hard to implement and try to make those connections with my patients who are maybe more vulnerable, stigmatized, or marginalized.
Thank you. I love these answers. All right. We're close to the end, and I want to give you time to close out with me with a message. So I'm going to skip to the last question that I have tonight. And as I said at the top, we're not going to solve any major issues today. Health inequity is a big and structurally based problem. And so it's important for us to focus on the things we actually can do to make it better for patients here in the here and now as we work towards the idea of health equity. So patients knowing their rights is one way to do that. What additional advice would you offer to the patients and people you serve to ensure that they can get access and get the most equitable care possible in this moment?
One of the things that I do is when I'm referring patients to another provider, I try to coach them through their next visit. And I say, listen, in order to get the most impact and benefit, to get the most answers and to get you on your way to a treatment, intervention, whatever, at the next provider, this is how I need you to show up. I need you to think about how you're going to present this information clearly and concisely. I need you to think about when did it start? How's it going? What made it better? What made it worse? Just trying to clue them in on what providers are looking for. And sometimes I have to flat out say, like, if you go in there acting like this, you're not going to get anything out of the visit. You know, this is the best provider for you to see. This is the smartest, most brilliant person in there in this field or in this area of expertise. Please don't go in there looking for all this warm and fuzzy that you get here. You got to go in there. You got to provide the information so you can get the answer, so you can get the treatment, so we can solve the problem, so we can get you back to living or whatever. And I think that if all of us helped our patients in that way, to have a more focused visit, to have a more successful visit, I think that that would be so incredibly helpful, you know? And I think the same for our providers. Like, we can offer that to our providers as well. You know, like when we write those patient surveys that everybody, I don't know how it is in Canada, but here in New York, like if your surveys aren't answered and everybody's not giving you glowing remarks, like people call you out on it at higher institutions, and it may impact our reimbursement in the future. That's what they're moving towards. And so I think that patients can also help providers by instead of just complaining about the wait in the waiting room or, you know, these random minute things, like really say what the provider is doing good and saying it. If I suck at something, tell me. I want to know so I can do it better. If I offended you, I need to know so I can do it better. I think that's something that we can offer patients as well in order for them to get equitable care. I didn't feel seen. I didn't feel heard. I, you know, went in because of whatever and all. And they just had a friend who has a huge mass on her leg. And the person who was supposed to biopsy it said, have you considered bariatric surgery? Like, what did you take a history? Did you do a physical exam? Like, this is inequitable care. These are the things we keep hearing about and talking about. And, you know, that person needs to be informed, like, you did this, it didn't work, it didn't get to the root cause of the issue, it didn't solve the problem, didn't answer the question, it was not good, equitable care. So I think it has to be both ways. We can't just put the onus on the patients alone. Providers can take the time, show up better, and really, you know, pull back the layers and get the information they need. But most of us, unfortunately, don't take the time.
Mm-hmm. I really do think it starts with us as clinicians, especially. So, for example, you know, I treat patients, oncology issues, lymphedema. I do not treat pelvic floor issues. And I bring this up because a lot of my patients will experience pelvic floor dysfunction as a result of their cancer treatment or because they had pre-existing pelvic floor dysfunction. So what I need to be doing is I need to be screening my patients, asking the questions of, are they experiencing this? Is this something that they want help with? So that means that I need to take the time and put in the effort to ascertain this information. And then I really love what Dr. Gaffney said about kind of like coaching patients on now what, right? We've identified that this pelvic floor dysfunction is bothering you and it's something that you would like help with. I'm not the clinician who can help you best. However, I know the best person who you need to be seen in my area. And so here's what the next steps are. Here's what we need to do. Here's what you need to do. Here's what you need to ask your physician for, right? If I don't have a relationship where I can just call up the physician and say, hey, we need a referral to blah, 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 blah to get this service, I may need the patient to also show up and advocate as I am advocating for them. Like we kind of need it happening from both ways to make sure that patient does indeed get that connection to, again, maybe the pelvic floor physical therapist down the road. And not only can we get them the referral, but then actually go and get that treatment. So again, what kind of education can I be doing so that person knows exactly what to expect when they go in? They're not surprised by, whoa, like we're doing pelvic floor stuff for my pelvic floor dysfunction. Like, don't assume that the patient necessarily knows exactly what's coming, especially if you haven't talked to them about it. So I think that's a big thing that, again, it really needs to start with us. And then how can we coach and educate our patients on what's to come, what to expect, and how they need to show up and advocate for themselves very specifically to achieve that end goal.
And I agree. I work in a very unique situation as well, and we get a lot of referrals. We have a great team, and we get a lot of referrals from naturopaths and dental hygienists. So they're seeing things starting before patients are already acknowledging it or feeling it. So I think the biggest thing is equipping those individuals with knowledge and who the individuals are that can treat that. And I always say to the patients, give me all your information. I want it all. So even if you think it doesn't matter, that fall you took 5 years ago and you broke your hip, that's important for me to know. Or the information like mom had very large legs growing up and the doctors maybe just said that, it's hereditary, you're going to look like mom. I want that information. Give me it all. You're not going to bore me. So that's extremely important. And it's just really important for the patients that we deal with is connecting them to the proper people. So your path isn't going to end with me, and I'm going to send you off to other people to make sure that your entire body, we're looking at you holistically. So nutrition, naturopath, dietitian, things like that. So yeah, I throw information at them, but I expect information to be thrown right back at me as well.
Beautiful. All right. This hour has gone so fast. We have about 2 minutes till 9. We may go a little bit over, but I want to give you all a chance to talk about one thing you wish more people knew about health inequities that would help them show up better in healthcare spaces and get better treatment. Anything you think is important to the discussion we didn't touch on today. So whoever wants to go first.
Is this for patients or practitioners? Can you clarify that for me?
Either one, whatever you think is important. What's on your heart, honey? What's on your heart?
So many things.
So many things.
Oh my goodness. I feel so many things, right? I think that we as clinicians, we're expected to do continuing education on an ongoing basis to keep up a certain level of competency for our licensure. It's the same thing here. We have to always be exposing ourselves and educating ourselves on this information because, how much information has come out within the last 20, 30 years about how medications affect different people differently. And we just had no concept because, again, women and everyone who was not a middle-aged white male, were not included in these trials to understand how do drugs affect a person. Yeah. And so I think we really have to hone in on this concept of, again, this is not justification to treat people as less than, but we have to understand that every patient is a new, unique body with different lived experiences and sometimes just different, how their body works. And so we have to consider that when we are taking best practice and what we know to be beneficial for patients, we are going to have to mold that to our patient if we are going to both, me as the clinician and my patient, work together to achieve our goals. So I mean, just like constant exposure and education of self to new ideas, new perspectives, and new information that's coming out.
Well,
That was the
thank you.
Condensed version of all these thoughts I have.
All right, who wants to go next?
I think just continuing to speak up. I think when we acknowledge when we missed something, or when we acknowledge when we were wrong and the patient was right, like taking a moment to share that with your colleague, to share that with administrators, to just share it, right? To share it with your staff that we're not always right. Sometimes the patient is right and we were wrong. Sometimes we missed it. Or to point out ways in which we could have shown up better, that we might have gotten to answer a diagnosis, a treatment, an intervention sooner, and to continue to raise issues about time constraints, raise issues about patient-related issues. There's so many things that I get called out and dinged on because I don't turn away my late patients, and so I have to work them in, and I take all the time that my patients need to try to get all the information and get the best outcomes. And to just explain that, and explain when I made these incredibly hard diagnoses that 10 other doctors didn't make, to explain when people were repeatedly dismissed, or they saw other providers who didn't get to the issue when I did, because we took the time, right? If we don't consistently call those issues out, if we just say, well, I'm different, and not explain how and why we're making a difference, then we won't raise awareness. If we don't raise issues of when our patients are falling through the cracks, we won't be able to catch those people. And sometimes we have to call that out. We have to just call a spade, as we say in my community. And we have to do it without fear, and we have to do it knowing that it's the right thing to do for the people that we are serving. We're not just showing up to get a paycheck. We're not just showing up doing something to say we did something for 8 or 10 or 12 hours a day. We're showing up to help people get better. And there's so many ways to do that. Sometimes people even just feel better just because they felt heard, and they didn't feel heard in any other space that they were in. So I think making people listen, and pointing out where the way that you show up is producing different outcomes than sometimes your peers and your colleagues can, and to just bring it back always to serving our patients.
And I will echo that. Communication and education, a different level. Taking it to the administrators to educate them on the importance of having that lymphedema awareness right after those cancer surgeries. We, at one point here in Ontario, we used to have lymphedema clinics or lymphedema awareness centers after the cancer surgeries, and the funding is gone. So, we see a lot of those patients now in the community, pathways and doors are open for them, and they're just kind of in the community lost. So, constantly raising the awareness, that the importance, showing the statistics of the changes in these patient outcomes since the closures of these clinics. But, that's the biggest, I think, most important thing we can do is communicate every time we are in the space. We're talking to those people. We're educating our patients so they can advocate when they're in those spaces as well.
Thank you guys. This is so beautiful. What I'll add to that discussion, I think I tell a lot of my patients, is that when you're in a healthcare space, you need to follow your gut. You're not going to be rude to a practitioner. You're not going to speak to them, out of pocket. But if you don't think you're getting the care you need, not getting the advice you need, ask for a second opinion, find another way, because you know your body better than anybody else. I think that's really important.
That's right.
To add that. I just want to say thank you guys so much for being here, speaking so eloquently, passionately, and confidently and clearly about all these issues. I really loved it, and thank you so much for being with us. We really appreciate it. And thank you. Our evening together is done. So we're going to end the live here. Thank you, everybody, for watching. We appreciate you as well. Have wonderful evenings, everybody.
Thank you.
Thank you.